Hey, y'all, welcome back to the Don't Mom Alone podcast. I'm your host, Heather McFadden, and this is the place where I get to walk alongside you and connect you with people and resources so you know that you don't mom alone. And today I'm welcoming back to the show Dr. Kamilia Smith.
Just know that you deserve to have your symptoms treated and that you deserve to be able to have a conversation with somebody who's willing to have that conversation with you. And you don't have to dismiss your PMS, your perimenopausal symptoms. We need to stop ignoring the other stepchild. It was menopause for so long, and I think we are grossly underestimating how women are feeling and suffering.
Dr. Smith is the founder of a local clinic here called Charleston House, and she came on the show last January to talk and answer questions about women's health in general. Since that time, I feel like I've learned a lot more about menopause, and the hot topic now, if you've seen the Holderness family videos even, is perimenopause. And so today we're talking about that. We're doing a deep dive into the different hormones that are fluctuating. I got some blood work done, so I'm bringing up, what does this mean? What are these letters and what does this mean? And how do all these hormones interact? And she's just here to help guide us and to know what's going on with our body, what are some symptoms you may see, how to work with your doctor to help alleviate those symptoms and move you through the perimenopause state that is so often neglected in healthcare. So let's get right to it. Here we go. Dr. Smith, or Kamilia, as most of us are fond to call you. Thank you for joining me again, a little over a year later, to help all of these women who are so confused about what is happening in our bodies post child production years. Thank you for guiding us. So last time you came on, we were talking about menopause and the stages of menopause, and I was clueless. And then soon after, it's like the hottest topic is perimenopause and what is happening in our bodies. And so even more keeps coming out and more products keep coming out. And so we thought it'd be fun to have more of a conversation. So you've even been learning a lot about it. When you get women coming in your office, around what ages do they tend to show up thinking, I think I'm in, things are changing. I don't like my body right now. I'm emotionally off. I'm gaining weight. All the things, all the symptoms start coming up. About how old are they?
It can vary from woman to woman, but typically it's once the reproductive years have sort of passed, right? You spend your 20s trying not to get pregnant, your 30s trying to get pregnant, and your 40s trying to figure out why you feel the way you feel. And so I think it's somewhere between when you wrap up those reproductive years, if you're looking to start a family or have a family, I think when that starts to wrap up, women start to pay attention to their bodies differently. And they also have a burden in their life of caring for those below and above them, that sandwich generation that we have, that term that we like to use, really especially pertains to women in their late 30s and early 40s. And so I think that's really a time when women start to go, okay, I don't feel my best. I certainly don't feel like I did before I started having children. And I'm wondering if it has anything to do with my hormones.
Yes. And I know for me, I thought, I was like, is something going on? And then I missed a period for the first time. And I didn't know if it was stress, and I didn't know if I was pregnant. And so I sure did take a pregnancy test.
Right. Well, and I mean, menstrual cycle is like a vital sign for me.
Yeah.
What are your menstrual cycles doing? And when I have people working in my office or pre-med interns, I'm like, you can learn so much about a woman from her menstrual cycle history. And so you really want to dig deep into that. And to your point, one of the things that will change first, not in everybody, right? None of us follow a textbook, and we're not, these perfect little scientific models. But one of the first things you will see is a disruption in the menstrual cycle for a woman who's always been regular. And a typical menstrual cycle could be about every 28 days, all comers, typical. But you'll start to see it shorten to 21 days, or you'll start to see it lengthen to 35 days apart. And so that vital sign can be very important to let us know. And it will wax and wane. And maybe you have 2-3 months where you have a shortened menstrual cycle length, and then you click back in and you're going as you would expect every 28 days. And then you maybe go every 35 days. And so you'll see that women will often report that their menstrual cycles have changed. And that is oftentimes the hallmark of what perimenopausal transition can begin to look like for women. So pay attention to those menstrual cycles because they are very important.
Well, and I didn't know until I just went to my OB-GYN or I just had this blood work done with Function Health. There's a thing that they can look in your blood that says how many eggs are left.
Yes, yes.
Like a measure. It's a get. I mean, it's not saying like literally there are 3 eggs left. I mean, but a measure. Is that the AMH?
Yeah, so let's talk about AMH,
Yeah.
anti-Müllerian hormone, and it's a hormone that's made early so it's made by really early growing ovarian follicles. And menopause is defined as loss of ovarian follicular function. Ovarian meaning your ovaries, follicular meaning the follicles that make the eggs every month. And so menopause is defined as the loss of ovarian follicular function. And AMH, an anti-Müllerian hormone, is a hormone that's made by these ovarian follicles in their very earliest stage. So you're getting really early follicles as they're shooting out this hormone. So you're not testing old follicles that have been hanging around looking to die off. And so it's a really good marker of what we call ovarian reserve. Now, I will say we are talking about perimenopause today. This is a different conversation. I have a completely different conversation in my office about AMH as it pertains to your fertility. But I like to look at AMH for a lot of reasons. That's you could do a whole podcast on AMH. But I like to look at AMH in my PCOS patients. I like to look at AMH in women who have documented infertility and have had like a year, 6 months to a year with unprotected intercourse and the inability to conceive. But when we're talking about menopause and perimenopause, we really look at AMH. I mean, you are given all the follicles you're ever going to have. You max out, you peak as you're a 20-week-year-old fetus. That's your peak. Right? We say, I always tell my kids don't peak in high school. Well, we peaked in a utero with our ovaries around
So
20.
so I want to make sure moms catch this. So we as women, when we were in our bio mom's womb
Mm-hmm.
at 20 weeks gestation. Is that what you're saying?
Yeah.
So like when that ultrasound is happening and they said it's a girl, that's when that girl had the
She
most
peaked. Yep.
like follicles being potential to have eggs. That's crazy. If that's your first time hearing that,
And then you're just
welcome.
on the downhill from those follicles, right? And
Yeah.
so the median age of when a woman really starts to have this drop off, or it's more clinically apparent because her menstrual cycles are changing, that's around 47. So perimenopause is about 4 years prior to that final menstrual period. But just back to the AMH, so we finish up on that. You can measure AMH in a lab. You can measure FSH in the lab. I personally think the FSH is the most sensitive. I call FSH the messenger, and we'll talk about FSH. But AMH, when it becomes undetectable, it gives us a lot of ability to kind of predict the timing of when a woman's going to have her final menstrual period. And so it's really, though, only supposed to be used in women around 47 or 48 is what I've seen kind of in the literature, and I've seen the experts really talk about. And much of what we know about AMH, we've derived off women who go through menopause early. So the average age of menopause in the United States was 51. We've kind of pushed it out to 52. So if perimenopause is 4 years prior to that, around 47, you'll see that AMH really start to decline. But if a woman goes through menopause before 45, she's considered early. And if a woman goes through menopause before 40, she's considered premature or premature ovarian insufficiency. So if I see an AMH that's low in a woman in her 40, 41, really don't know what to do with that because it can be bounced. It doesn't, it's really harder to say what kind of prognostic value it has. But as a woman ages, it's very, very prognostic about where she is in that menopausal transition.
And most OB-GYNs will like if a woman listening goes in, okay, you're shaking your head no. If
No.
if a woman goes in and she's 47, 48, this is me, y'all. I turn 48 next month, okay? I come in and my OB-GYN tested for this, but if yours doesn't, this is maybe you should ask.
Well, and the reason AMH is hard is when you read that lab value out, there's such a wide range.
Yeah.
So what
Yeah.
does it mean, right?
Yeah.
What does it really mean? There's such a wide range. But I think it's pointing to the fact that labs are not reliable in a woman because our levels change minute to minute, hour to hour. So you really, to take a picture like a photograph of one point in time on a woman, those labs can be not as helpful. And so we'll look to things like an AMH to say, okay, where is she along this way? But we haven't been given standard values. We haven't been given like standard values to say, well, if an AMH is below this, then she's surely perimenopausal. Like that doesn't exist. And so, while we use it as a tool, so if I see a woman with an AMH that's above 1 and she's 47, I know she's got a ways to go. But if I really rarely see that. So,
But if it's point 0.1,
yes, that's where you'll see it is in that less than 1 range a lot of times.
okay.
And you can see that at 42, 43, and she's still cycling. Because remember, this is a measurement of early growing ovarian follicles. And so as those ovarian follicles are starting to die off over time. And so it's a great test. We love it. You know what we love about it? You can be anywhere in your menstrual cycle and we can check it. But I do think, hold on, stay tuned. We're going to learn more and more about the clinical relevance of what an AMH means for a menopausal woman. But you have to remember too that menopause is a clinical diagnosis. And what I mean by clinical is we don't need labs to determine whether you are or you aren't. It's a clinical diagnosis, right? So if you stop having periods and you've gone a year without a menstrual cycle, you're menopausal, right? I didn't need labs. I needed you in front of me to tell me what your menstrual cycle, your very important vital sign, is doing. But what I really like and I think is very helpful is an FSH. And so I think we should talk
Tell
about.
people what that stands for.
So FSH is follicular stimulating hormone. It is made in the brain. The FSH is made in the brain. Remember, AMH is made by those ovarian follicles directly from the source, directly from the ovary. But AMH it's telling you what the behavior.
FSH.
FSH. It tells you what the behavior of your ovaries are, right? Like, okay, so I could be making follicles, but are my ovaries really behaving like a 49-year-old or are they behaving like a 39-year-old? And why the FSH is important is when FSH is made in the brain, it tells the ovaries to make estrogen. Those follicles start to produce the estrogen, and then it loops back in a negative feedback loop and shuts the brain down and says, hey, you don't need to tell me to make any more estrogen this cycle. We're good. I made you a big fat follicle. We're good. Shut off the brain. Don't keep stimulating the ovaries this cycle. And so I always liken it to if the ovaries are not behaving, like if your child doesn't listen to you and the messenger's like, okay, you're not listening to me. You're not doing what I need you to do. I'm just going to talk louder so that you behave. And so the messenger gets louder and louder to tell the ovaries, and the ovaries really do try to keep up. That is why sometimes you will see really high estrogen levels in women who are perimenopausal. You'll see them sometimes 2 to 3 times of what you would see because the ovaries are just being pounded with that messenger. So the messenger gets louder and louder and louder, telling the ovaries to keep up and produce that estrogen. Eventually, it will shut it off. But when I see a woman who's perimenopausal and she thinks she's in menopause and her FSH is 2, I'm like, that's really not a loud messenger. A loud messenger is going to be in the 30s to 40s. And what's really important about FSH is if I put an estrogen patch on a woman and I measure her estradiol level, what was undetectable before is now measurable to some degree in the lab. We don't necessarily go off that. I want to say we treat the woman in front of us and treat her symptoms, not the labs always. But I can measure that estrogen. But what I can't change is that FSH because the estrogen I am giving her is not coming from the ovaries, and you don't get this negative feedback loops. You actually get loss of a negative feedback loop, which is like a double negative. So the FSH stays high. And so what this means is if a woman is on menopausal hormone therapy and her FSH is in the 30s to 40s, that's a pretty significant messenger. It can bounce in and out, but when you start to see that FSH creep into the 30s or 40s, you know that you are losing the feedback from the ovaries. And then, in somebody like me at 49, my FSH was over 100. That messenger was like screaming at the ovaries to make some hormones. But what's interesting is you can give a woman hormone replacement therapy or give her menopausal hormone therapy, whichever phrase you like to subscribe to. You cannot change the FSH. So you'll get their labs back and their FSH will still remain very high. If you get your labs back after starting on hormone therapy and your FSH is now low, that isn't because they gave you hormone therapy. It's because your body is kind of bouncing in and out, and that messenger's like turning on, turning off, turning on, turning off. And that's why women can get really pronounced symptoms of high estrogen one cycle with breast tenderness and bloating, and then the next cycle they may not have those symptoms. And so it's really because of this relationship between the FSH and the ovaries trying to keep up and produce that estrogen.
All this talk about perimenopause, whatever stage of motherhood you're in, I find that my ability to handle all the triggers of motherhood goes down the less I take care of myself. And it is just really hard to make time for self-care. So I have a really cool, simple, practical, adorable option for you to add self-care into your life. And it is called Give Hugs. It's this weighted plushie. They're not just cute. They are the ultimate cozy companion. They're perfect for relieving stress, soothing cramps, or just helping you relax after a long day. We have a turtle one, and my boys will sometimes fight over who gets to use the hugs. I mean, it's so stinking cute. It has non-toxic glass beads inside, and they donate 10% of their proceeds to mental wellness charities. I'm just telling y'all, whether you're treating yourself or you're looking for a thoughtful gift for someone special, maybe a friend or a loved one, these heatable, coolable plushies are a hug you can hold on to. Check out givehugs.co, that's C-O. Use the code DMA to get 20% off your first order. Trust me, you're going to want one for you and one to share. That's givehugs, and hugs is with a Z. givehugs.co. And use the code DMA to get 20% off your first order. Okay, I'm going to say back what I think I thought you said so that we can make sure everyone listening also got it. FSH is talking to the ovaries and saying, make more estrogen. When it does, the estrogen then talks back to the brain and says, you can stop sending out that hormone. We've got enough. If we add in estrogen through a patch or whatever replacement therapy, that is not necessarily communicating to our brain to say stop making the hormone.
Correct, because it's not coming from your ovaries. It's coming from
Because it's a false source, which is interesting to me. You would think that just the presence of estrogen would cause the brain to say stop making FSH. We're good.
Right.
But just because it's not coming directly from the ovaries.
And yes.
That's super interesting to me.
And this is a really nice segue into this bioidentical term that I hear. And I hate to be the whistleblower on this, and I might get some hate mail from this.
Okay, don't cause me to get hate mail. Please send all email to Dr.
Marketing term. And how do we know that to be true? Because you can give a woman bioidentical hormone therapy and her FSH is still high because it's not the same as what her ovaries were making it to shut off the brain.
So people that say get the bioidentical, that's the way to go, you would say it doesn't really.
It's all still made in the lab. It's all still made from the same early derivatives of estrogen from plants. I mean, like, it's not any different. And what's really interesting is people will say, well, hey, listen, I'm giving you bioidentical, so it's exactly what your body makes. And yet every person I see on bioidentical hormones is walking around with the same tube, with the same dose.
Okay, so you mentioned some like symptoms related to the FSH going up, but like, is it a problem if we're adding in this estrogen? It's not communicating with the brain. It's making more hormone. Like you said, your FSH was in the hundreds. Beyond like the estrogen 1 symptoms of breast tenderness 1 month, like, is there any problem with that? Like, are we?
Well, so good segue into how do we treat people who are perimenopausal when they are making estrogen really high levels some months, and then some months their levels are undetectable in the lab and they feel like they're on the floor and they feel terrible. So yeah, and I always tell women, I can make you better, but I can also make you worse by just trying to layer on things on top of what you're making erratically. You know, something you and I talked about early on at the beginning of this when we were offline is when we met a year ago, we really focused on menopause, right? Because we were like, hey, listen, we've really neglected women in menopause. And I would say that if we've neglected women in menopause, we have greatly neglected women in perimenopause. And right now, menopause is the hot topic. And it's like, when will we learn, right? Like, women need, they need treatment for their symptoms, but everybody's so focused on menopause. And in reality, you actually feel really much better once you get over the transition. It's that transition, it's that menopausal transition, it's the perimenopause that does not get the credit that it deserves. And I don't remember if I said this last year, but it still holds true. A 48, 49-year-old woman, 47, 40, let's just call it 47, 48, 49-year-old woman, oftentimes is the hardest woman in my office to treat, because she is going to do things differently, and she's going to do them differently from month to month. And you have to play defense a lot of times, and you have to really lay out what the menstrual cycle actually looks like and why is she having these pronounced symptoms. Because you can have women who feel really terrible right up towards their cycle, and as soon as their cycle starts, they begin to feel better again. Well, that's because their
And
estrogen.
feel amazing.
Yeah.
Like, literally, my cycle just ended, and I'm like, I've never felt better in all my life.
Yes, because your estrogen's climbing again, right?
It's
Then
annoying.
it climbs so high because that messenger, that FSH, is just cranking it out, that you're like, why is my PMS so bad?
Yeah.
Why are my breasts so tender? Like, why? And so that perimenopausal transition, I would say, is the bigger stepchild than neglected
And
stepchild
actually
than menopause
menopause.
ever was, because menopause is so much easier to treat than perimenopause. But can we make somebody better or worse? We absolutely can. So if she has bouncing around with her estrogen production, and she's up and down and up and down, and I bring in menopausal hormone therapy that is not like, she's standing on her toes and I give her a little bit of menopausal hormone therapy, that's like just barely cracking the surface. I can accentuate her symptoms that are due to a lot of estrogen, circulating estrogen that she's making on her own. So number one, I can make it worse because I'm adding to what she's making. And number two, I can't get above what she's making and suppress it down. So she's still going to feel those fluctuations. And the fluctuations are really where the highs and lows, that's where really women are suffering, is on that slope of that curve between the highs and lows of their own hormonal production.
This is helpful. This is helpful because in my mind, I thought, I'm going to make the appointment with the OB-GYN. I'm going to get on some estrogen. I'm going to feel better. That was like my thinking. I go into the appointment. She hears my family history, which is a lot of cancer. Okay. Just like everybody's got the cancer. And I think she was like, I don't know that we should be adding hormones if your mom had breast cancer and your dad had colon cancer, and you had skin cancer. Like, so I got to go see a cancer geneticist.
Mm-hmm.
The good news for everyone listening that even cares about my health, I have no gene mutations. That's the praise. So good news.
That's great.
But I'm going to go in today, this afternoon, and you're saying that if she just gives me more estrogen, it could make some things worse. These fluctuations are not going to go away for the next couple years.
Right.
So what do I
So I
so
have
help me.
so many thoughts on all the things you just said. Like,
Yeah.
I, wow, my mind is blown. Number one, a majority of breast cancers are not due to a genetic predisposition. So let me say that again. A majority of breast cancers that run in families, or familial breast cancers, are not due to any identifiable genetic mutations. We have identified gene mutations, BRCA, but BRCA comprises a very small portion of familial genetic mutations, meaning most families that have breast cancer running in their family are not BRCA. It's just the very first one we were able to identify. So it doesn't get you off the hook. And I would tell anybody that's listening, if you're worried about your genetic predisposition, then you always test the affected individuals. You test the mom, you test the grandmother, people who had cancer. You always want to test the affected individual. And if they don't have a genetic mutation, that shows you right there that does not get you a free pass, right? Number two, I take ovaries out of BRCA patients all the time, and then we put them on estrogen. Well, how could that be if estrogen causes cancer in genetic mutation carriers? No, we've decreased their lifetime risk of breast and ovarian cancer by removing the ovaries. But all of the studies, and there are beautiful papers written on this, that show that a woman who has a BRCA mutation and you take her ovaries out and then you put her on estrogen, you will increase her lifespan, and they will not have an increased risk of cancer. Point blank, like, period, end of story. So it's a very important thing for people to understand. And if your doctor doesn't know that, they absolutely need to read the papers on that. We have a lot of population studies on BRCA because of the Ashkenazi Jewish population, and that
Yeah.
has afforded us a lot of valuable medical information.
She's like, "You don't happen to have Jewish heritage." I was like, "Well, shoot, dang, yes, I do." That's fun. I didn't know that connection.
But all of my BRCA patients are on hormone therapy after we take their ovaries out because we took them out young. And if we didn't, their lifespan would be shortened. And it has been shown time and time again, it does not increase their risk of breast cancer and it increases their lifespan. It's a very important thing to understand.
Yeah,
Number
that's good.
two, your lifetime risk of breast cancer that you got from that genetic counselor or whoever should have calculated a higher Cusick score. That's your lifetime risk of breast cancer. That's your TC score. If it's over 20%, you are in a higher risk category. You need more increased surveillance. But let me be very clear. Estrogen does not cause cancer. And if we have to go back to the WHI study, we will go back there. But in the WHI study, the women that only got estrogen, they did not get progesterone because they did not have a uterus. They had a decreased risk of breast cancer. And what's really important is their risk was lower than the placebo group who got no hormones. So it had some protective effect over their lifespan. So we have to take all these things and say,
Yeah.
before we jump to you can't be on it because it causes cancer, let's pull more data in on the woman. So for TC scores elevated, maybe it is a little bit more thoughtful conversation of like, hey, if you have a cancer and it is estrogen receptor positive, we could be feeding it. Does it cause it? No. And the really nice way to think about this is if you have a tumor in your breast, the tumor has turned into a tumor for reasons because of its own tumor suppressor genes turning off, tumor growth genes turning on. That estrogen does not turn on or off those tumor suppressor genes and those tumor growth factors. It does not turn that on. But when those genes get turned the wrong way, if you turn off a tumor suppressor, you can cause cancer. If you turn up a tumor growth, you can cause cancer. When those genetic things turn on or off, it's not estrogen that does that. But when they do, you have estrogen receptors all over your breast tissue. They become very, very hyper responsive to estrogen. So did the tumor get caused by estrogen? No, it got caused by probably more likely overuse of alcohol, a higher BMI, smoking, those types of things. That is why women get cancer, and those tumor genes or those tumor modulator genes that govern over those sequences, whether or not a woman gets cancer, those are turned on and off by other things. So we talk a lot about hormones, but alcohol increases your risk threefold for breast cancer over hormone therapy. That is the conversation we should be actually having with women when we talk about, well, should I be on hormones?
Well, and then also you said BMI. I'm like, my weight has gone up so significantly. So like, if that would the estrogen help with that
I
or
really
no?
wish estrogen caused weight loss. It does not. I really wish it does. It does not. And I have some patients, and back to, I want to finish out something here, and I will
Yeah.
walk through this with my patients because I cannot predict what's going to happen with each woman. And if she's perimenopausal and she's just miserable, and we do think that a lot of her symptoms are due to low estrogen, I'm like, hey, walk this out with me. Let's do
Yeah.
3-4 months this way, and let's do 3-4 months this way. And then let's compare how you felt on the two. So I will reasonably partner with a woman and say, she's like, I'm convinced I need menopausal hormone therapy. I've seen it on every reel. This is the answer for my perimenopausal symptoms. I'm like, okay, then let's do this thing. Let's do it. Let's do it together. And so I will allow them a trial of it because it's not going to hurt them. The worst thing it can do is accentuate their symptoms, and they're going to come back and tell me that. And so we will try both ways. We'll try lots of different things. And I think that
What are the both ways? The both ways are
the
with
both
hormones and
ways will
without?
be adding estrogen across the board throughout the menstrual cycle and progesterone.
And that's like a patch? Like, what are we
It,
talking?
var-
Like, that's a
it
shot?
varies. It
Okay.
varies a lot. We have an IUD in. We've achieved amenorrhea or no periods because of the IUD, but physiologically she's still ovulating, and we can tell based on her symptoms. So we'll layer on a patch and do that either cyclically, or we'll do it across the month because she's convinced I really have to have it, or we'll do it when that menstrual migraine starts to develop. We'll put on that estrogen, recognizing that's a nod that she needs the estrogen to protect her before she starts to get a migraine, because those can get really worse around the perimenopausal transition. Premenstrual migraines will really, really peak in frequency for women. And so we'll do lots of different things. We'll suppress ovulation with a progesterone only pill called Slind, and then layer on a patch. Like you really have to find a physician or a PA or nurse practitioner that has a lot of knowledge that's willing to walk you through the various approaches and the ins and outs so that you can have some skin in the game and understand why you're taking what you're taking so that you know how to assess whether or not your symptoms got better or worse during that trial.
So what I heard you saying was that before we're actually in menopause, before the cycle has stopped, when we're still in these fluctuations of hormones, that your treatment would be fluctuating as well.
It can, yes.
That it's not like I was with a friend and she puts on a patch on Wednesday and she puts a patch on Sunday
She's using
every
a
week.
patch twice a week. Yes. That's how it
But
should be.
that's different than what you're saying.
No, that's not different.
Okay.
No. That's just the half life of the patch. I did see a patient in the office last week, and her symptoms were worse because she was put on estrogen to see because she was concerned about her weight gain. So she was given estrogen. Well, that drove up her anxiety. So then they just kept cranking up the estrogen and cranking up the progesterone. In reality, she was only ever started on it for perimenopausal weight gain. And I was like, wow, I love the idea that estrogen can make you lose weight. It actually doesn't. That would be amazing. And we have smarter drugs now for weight loss. Like we microdose the GLP drugs, using them very safely in a way that maybe isn't seen around town necessarily as common practice, but you can microdose these drugs really well and sort of counteract some of those effects that you see as a woman ages due to changes in weight fluctuation. And listen, weight fluctuation is not just a hormone deficiency, okay? It is not. For reasons we just talked about, women can get super high levels of estrogen. So that's why she's gaining weight. She's, cycling throughout and having a little bit of higher levels of estrogen. And that can be what she's sensitive to as far as her weight redistribution. So it's different for everyone. But in midlife, middle age, around the perimenopausal, menopausal transition, we become more immobile. We're not sleeping as well. That's weight promoting. We eat differently. That's weight promoting. We move less, also weight promoting. And hormones is just one little tiny prong of that whole thing. But people are like, I can't lose this weight. It's got to be my hormones. And if that were the truth, then just giving women an estrogen patch would fix that. In my practice, we do a lot of in-body scans on our patients. They have access to our in-body scanner, and I can look at visceral fat distribution and how it's fluctuating. Some of my patients, they have access to fancy DEXA scanners, and they can see how their weight's fluctuating with or without the addition of estrogen through the menopausal transition. And what I have seen is that estrogen does not cause weight loss in a way that warrants using that for that reason.
Does it so it's not gonna help with weight loss. Does it help with the mental health piece? Because I will tell you, leading into that, during that PMS, even just, once the ovulate the mid-cycle until the that period of time, no bueno.
It absolutely can help be a mood stabilizer. It
Okay.
doesn't necessarily replace something that's treated for mood disturbance, but use it in conjunction with an antidepressant or use it in conjunction with an anxiolytic medication.
What's that word you just said?
Anxiolytics, so like those are medications that I always say lytic is to like cut something. So an
Oh, okay.
anti-anxiety medication, anxiolytics is what we call them.
Okay.
I mean, we see a rising prevalence of mood disorders, cognitive disorders, so ADD, ADHD, depression, anxiety. We see a lot of that in the menopausal transition due to those hormonal fluctuations. And I mean, like I've seen patients who maybe have always been able to suppress some of their anxiety or their ADD. Maybe they were just treated in college, and then when they were out of college, never took medication again. And here they are in their late 40s needing it again because they're overwhelmed and can't get through the day. And so you'll see that some of these mood disturbances or cognitive changes can be transient during the menopausal transition, but they can also really peak. I've seen patients who have narcolepsy that really started to peak in the menopausal transition. And so we had to treat that appropriately. While putting them on estrogen is great, and there's so many other benefits, it is not always the only thing that they will need. And so when I see patients that are under medicated for their depression, so let me give you an example. A woman has always been on Zoloft all of her life, and she's on 25 milligrams. Well, it's a very subtherapeutic dose. And she sees a psychiatrist consistently, who's not made a medication change in her regimen for 10 plus years. And then she goes through menopause, and her psychiatrist is like, you need to go see somebody about that. It's your hormones. Well, while it is her hormone, she's also has a longstanding history of depression and anxiety that has been under medicated. So what do we do in those patients? I'm like, let's utilize the medication you're on to its maximum potential, recognizing that this hormone deficiency is it's at play there as well. And let's treat the hormone deficiency. But let's not leave you on a subtherapeutic dose of Zoloft that really isn't doing anything because it's not given in a way that it could do something, if that makes sense.
Yeah, no, that makes sense. And I think that what I'm hearing versus like maybe the conversation a year ago, it was like, no, we need to give women estrogen. Like, don't be scared that it'll cause breast cancer. I got the best surprise yesterday. I had completely forgotten that an order from Green Chef was arriving. And what is Green Chef? Well, it is the #1 meal kit for clean eating. And as we're talking about health today, I'm finding out more and more how important it is for me to stay away from processed things, to keep my eating pretty clean so that my hormones can stay regulated. And I was reminded how Green Chef helps me do that. And surprise alert, my boys loved every single thing that I made. And all 3 meals that they sent me had some form of fish. And I was thinking, is this going to go over well? And it totally did. One was a tilapia with this cauliflower, and they send you pre-made sauces too. So you're not doing all the work to make the sauce, but you know it's a sauce made with clean ingredients and so delicious. I mean, it was like I would present the plates and they were like, oh, this looks like it's from a restaurant. I know. I'm wowing them at every turn. And if you're someone who's like, okay, I'm going to eat cleaner this year, but you're kind of overwhelmed with finding the recipes, buying the food, preparing the food, I made all of these meals really quickly. And I know some of you are like, I've done those meal kits before and it takes forever to prep. I was even impressed that a lot of the things came with vegetables already diced, which if you're someone who doesn't know how to dice or doesn't enjoy dicing, it's really helpful to have that ready to go. So for this new year, check out Green Chef. They have so many different dietitian approved recipes. They have fiber support, which is also good for the perimenopause people, low saturated fat, under 700 calories per serving. And they even have salads available if you just need like a grab and go, less than 5 minutes situation, or ready to blend smoothies, protein packed breakfast. You know, we're supposed to eat our protein. They are going to keep you feeling energized, curb your cravings, get you through this year feeling better than ever. So check them out. We loved them. Thrive all year with clean, easy meals from Green Chef. Go to greenchef.com/alone-free. That's the code, y'all. Alone-free to get started with free salads for 2 months. They're going to send you free salads, okay? Plus 50% off your first box. So that is greenchef.com/alone-free. And that'll get you free salads for 2 months and 50% off your first box. And y'all, you're going to find out that Green Chef is the #1 meal kit for eating well. This sponsor is so easy to talk to y'all about because I literally use these products every day. It is my Thrive Cosmetics. And I've told you before, it's solving all the problems for me. One, they're 100% certified vegan and cruelty-free. So they have clean, skin-loving ingredients, which again, if we're talking about perimenopause, they keep telling you hormones can be in your skincare and in your beauty products and can impact your experience there. So just something to think about. But they're not just clean, because I've used clean products in them before and they don't perform. They don't last all day. And I had a speaking engagement yesterday in the morning and in the evening, and I was able to just put on my Thrive Cosmetics and know I was good for the day. Also, they give back. For every product purchase, Thrive Cosmetics donates products and funds to help communities thrive, communities that help support those with homelessness, domestic abuse, so many people in need. And I love that about them. But let me tell you about the winner, the one that everyone comes up to me and they're like, You were so right, Heather. It's the Liquid Lash Extensions Mascara because it lasts all day without clumping, smudging, or flaking. I don't know what it is about my eyes. I think they're deep set is what I've been told. But when I use any other mascara, I end up with dark underneath my eyes, not with this mascara. And it looks like lash extensions because my eyelashes aren't breaking when I remove the mascara at the end of the day because it creates this flake-free tubing formula, that's trademarked, around each lash. So it's lengthening my lashes, it's defining them, it's nourishing them, and it comes off super easy with warm water and a washcloth. It just slides right off. So celebrate the women in your life with Thrive Cosmetics. It is luxury beauty that gives back. Right now, you get an exclusive 20% off your first order at thrivecosmetics.com/DMA. That's Thrive Cosmetics, and it's spelled CAUSEMETICS.com/DMA, and you'll get 20% off your first order. What I'm hearing you say now, too, is giving estrogen isn't the solve for all the things.
No, but it definitely is something we need to be giving to women. And so we've swung the other way. Like, don't give
We shouldn't
it.
be afraid of it like it
Yes.
once was. But at the other end of the spectrum, I think, like you said, like on the reels when we're just getting pushed, like it's the magic to making everything better. Like that's in my mind. I thought, oh, I'll just get estrogen and then I'll just be better.
And what I would hope that everybody listening would walk away with, if there's one big thing, is there are these constellation of symptoms that occur during the perimenopausal transition, which is about 4 months prior to the full menopause transition. And so the average age is about 47. If we're saying the average age of menopause is 51, 52 in the United States. And during that transition, you can have a whole constellation of symptoms. And it can be anything from mood changes, attention deficit, migraines, frozen shoulder, joint aches, swelling of joints, heart palpitations, insomnia, night sweats. I mean, yada, yada, yada. One thing I don't see a whole lot of, and maybe this will be the next trend. If I speak on it, it'll show up in my feed. I'm not seeing a lot on the GI system and how that interplay with estrogen, but I think there's probably more to come. But as I'm working my way down a woman from top to bottom, and I think about mood, I think about sleep, I think about energy level, I think about musculoskeletal, I think about her heart, I think about her frozen shoulder, and then I go to her heart and the palpitations. Some women literally, you can put estrogen on them and their palpitations dissipate. And so I think that's important to understand. I mean, I've had patients who've had cardiac malformations or have had cardiac surgery for valve replacements and whatnot. And when they were in the hospital, every time they had a severe hot flash, they were on telemetry, they would go into like an arrhythmia. Like you can actually see that on women. Now, that doesn't replace somebody needing a cardiac evaluation, which we still believe in. But I would hope people listening would realize there's this constellation of symptoms that are all due to these fluctuations of estrogen and your hormones and the perimenopausal transition that we weren't treating with hormones. We were just sending them out to the rheumatologist, the psychiatrist, a sleep study. We were sending them out, practicing everything in a silo, making sure it had its own diagnosis. And now we realize the root cause is a hormonal deficiency that we should be treating. But I take it even further and say, but we should use the other tools in our toolbox that are really great to help stabilize that mood, to help with sleep, to help with weight loss and all those other things, because I don't know that estrogen can shoulder all of that on her own, is my point.
It's a good, very, very valid. And I know you said there was a new documentary out on, I know the M Factor came out that was on menopause. What's the new one that you watched recently?
Okay, so I'm glad you asked about that because we did not plan this, but there's an event that I would like to invite you to.
Oh, okay.
On Saturday, March 29th. It'll be at the Tower Club. And so the documentary series is called Balance. And it is these two monks. Women can be monks too. And so
were they at that viewing of M Factor?
Yes, they were.
Okay.
And so that's
I
when we
thought
had
so.
the really wonderful privilege of meeting them for the first time. They are actually local to the DFW Metroplex. And they have started, so they have some background in making documentaries. And they did one on sex trafficking a while back. I think they did something on animals. Anyway, so they've kind of really realized that this is something that they can make it's like another area that they can have an impact in people's lives. And so they somehow got tangled up in these documentaries. And then lo and behold, they go through perimenopause and they're going through it together. And when we say optimize your lifestyle, like meditation, mindful breathing, sleep, take out alcohol, eat clean. Well, these women are already doing that, and they are still having some really pervasive symptoms. And they're like, hold on, we can't maximize our therapeutic lifestyle changes any more than we already are. This is really something bigger than us. And we want to figure out what it's all about. And they couldn't find answers. And one has decided to do hormone therapy, and the other one has decided not to. And they go through a documentary, the two of them, as they're going through and trying to find answers to their medical questions. And so I have seen episode 2, I've seen episode 3, I've not seen episode 1. I'm sorry, I've only seen episode 2, but I've seen 2 showings of episode 2, a pre-edited version and the post-editing. I've not seen 1, and I have not seen 3. So they are having an event on March 29th. They are flying in speakers from all over the country. Dr. Newsom was the president of the International Society of Menopause. She's flying in from the UK. We have Lisa Larkin, who is the current president of the Menopause Society. She's flying in from Ohio. We have lots of smart people that are going to be on this day-long event. And what the hope is that we can create an event here in Dallas, raising awareness about perimenopause and menopause that really is for our home state. I think oftentimes when people outside of Texas think about women's health, it has a very, very, very negative connotation because of the political bipartisan issues. And what we're really hoping is that we can say that menopause and perimenopause has nothing to do with that. This is really bringing dollars back to our state, generating awareness and funds for our local women so that they can have a shot at really understanding how to navigate their own health. So that is the heart behind this event. This is why we chose Texas. It could have been in California, it could have been in Manhattan, but we chose Texas for this reason, and it will benefit their documentary. So all ticket proceeds will help support their documentary so that they can get that third one out, because it's still in development and there's a lot of work that goes into that. And so we're hoping that will generate awareness, but also generate some funds for them so that they can go on and continue to make good use of their experience. And then the whole was like, maybe Netflix will pick it up. And I was telling them, they came to my office the other day, and I was like, how cool would it be for a woman to get on an international flight, like on American, and 8 hours later know everything she needs to know about her health, right? Like she watched it while she was in flight. And so the pie in the sky is that we can get this information out to women globally in just very unique ways, entry points into their life so that they can get educated on this stuff and make it in a way that's digestible and engaging and fun. So I would love for you to come. You will love these women. They're fantastic. And there'll be lots of big names there that will be presenting that day.
And so they have experts come on and kind of
Yes.
give the input. So you're getting it through.
You're getting it
that's
through
awesome.
the tip top experts. And all their documentary series, they have interviewed so many physicians that I have a lot of respect for, who run, they run like the menopause clinic at Mayo and at Harvard and Cleveland Breast Clinic, cardiologists, psychiatrists, but really the people who've done all the groundbreaking research in menopause and perimenopause, and just understanding what are the things that change in a woman and how we should be approaching them from not only a diagnostic but therapeutic, like the drugs that we push through the FDA and those types of things.
So person listening, if she is experiencing a variety of symptoms, she's between 47 and 51, she's in perimenopause, this is something she needs to have a physician walking her through with her. There's not something wrong with her if things are fluctuating throughout every month. And if she's experiencing a variety of symptoms. And to me, what I heard was, once I actually get into menopause, this could be better.
Yeah.
But is that wrong?
No.
Like and I know that a lot of research will, maybe as women are in medicine and doing more research, like you said, you don't even have a good range for that, different hormones and.
Well, and just know that you deserve to have your symptoms treated, and that you deserve to be able to have a conversation with somebody who's willing to have that conversation with you. And you don't have to dismiss your PMS, your perimenopausal symptoms. We need to stop ignoring the other stepchild. It was menopause for so long, and I think we are grossly underestimating how women are feeling and suffering. And I think that you have to be willing to be the squeaky wheel and say, this is not enough for me. I feel like I need more options than this. and I need to optimize where I am in my journey, because I am caring for those above me and below me. And or maybe I'm reentering the workplace. My kids are out of the home now and I want to get back to what I was doing before. And women need to be able to sleep. They need to be able to feel like they have some sense of control over their body in a very out of control situation. And so you have to be very motivated to go and find somebody who's willing to partner with you on that.
And is there like one like question or thing, even today when I go see my doctor, that is it just the whole partnership concept, or is there something you would make sure a woman has a conversation with her doctor about?
What are my treatment options?
Okay.
Because doing nothing is not an option for me. Otherwise, I wouldn't be here. So, what are my treatment options? And go from there, because you should have options. And if they say, oh, well, this is just part of it, this is just part of life, you'll be fine, that's not a treatment option. And I really, unfortunately, still hear that from patients that come into my office to do a menopause consult. And they'll say, well, I was just kind of like told. But I do want to say this. OB-GYNs, we are not trained, as you've heard. We have not been trained. I had to pursue my own knowledge over the last 5 years. It's taken me 5 years to get to where I am now, and I still have a lot more to learn. But it's taken me 5 years, and I'm not trying to navigate, seeing pregnant patients all day, running in and out for deliveries, C-sections. I'm not up all night on call. So I'm not having to navigate that anymore. So even having said that, it still has been a journey for me to acquire the knowledge and to be able to approach patients in a thoughtful way and anticipate what they might encounter as we come on and off different treatment options. And so, give your OB-GYN a break. Number one, their schedule isn't made for this. They can't house this types of conversations. I mean, what we just did here is very similar to what I do in an hour-long menopause consultation. I really can't do it in less than an hour if it's a new patient, for sure. And their schedule's not built for that. So it's not like they don't care or your symptoms don't matter. It's that the house is not built for that. And maybe that will change. I think it is changing. We have lots of online platforms where women can get access to menopause care. And so just know that it is
I
not
could
the
even
thought.
see like residency programs starting to split you're an obstetrics, you're a gynecologist,
Yes, that would be amazing. Yes.
like a specialty in perimenopause and menopause, like that's your residency. And that is what you leave your residency, you start versus trying to do both ends of like, yeah, it doesn't make sense. A woman is too complex to get all of these smushed into one doctor.
But the signal or the message that we've sent us, is that since you're not pregnant, you're not trying to get pregnant, and you're maybe not necessarily have a surgical need indication for my practice, that those other symptoms they don't really warrant or necessitate an
Treatment, yeah.
appointment, much less
Mhm.
treatment. So that's the cultural message we've sent to the women, to all of us. And number two is, if you do find somebody that's willing to listen, what is their level of understanding of treatment options and how to identify if a woman's low, intermediate, or high risk based on the things in her past, with genetics just being one of them. We have to look at other factors. And are they willing to have a conversation with you, which we call shared decision making, and go through the ins and outs of what all kinds of treatment options could be at various stages of the transition for a woman. And so it's very complicated. And I tell patients, it's like a painting. You paint, and then you step back and you look at it and you go, you know what? I think I want to change that. And then we paint again. And then we step back, and 3 months later they come back, and then we look at the painting and see if we like it, and then we paint it again. And so it's very nuanced, if you will.
Why is this not easier? Come on. Come on. We appreciate you. Thank you for coming on again and sharing with us. And y'all, we'll put links to all the things in the show notes. Make sure you check out Dr. Smith.
Thank
And
you.
if you're in Dallas, check out her office, and the M Factor movie for sure if you haven't. And
Yeah.
then this new documentary, Balance. So thank you, Kamilia. So good to talk with you. And we will chat soon.
Okay. Sounds great.
Okay, so after I did that interview, part of me felt a little discouraged, like there was no hope. And maybe you're feeling that too. And I went immediately after I interviewed her and I had my OB-GYN appointment, and she gave me lots of over-the-counter options to help with my symptoms, and she even prescribed me to go on a birth control. And then I looked up the birth control and I was like, it looks like the side effects of this birth control are depression and weight gain. I don't need more of that in my life. So I'm doing more research. One of the over-the-counter that my doctor recommended, and again, you need to talk to your doctor, but I ordered it through Amazon, and you can also get it at Target. It is called, hold on, I'm looking it up. That's why it's taking me so long. I think it's called Amberin. Amber, like the name Amber, and then EN. And it helps with hot flashes and night sweats and mood swings and low energy and more. And it's reasonably priced. For 2 months. It's $50. So anywho, if you have an HSA, maybe it could help with that to get you through some of those symptoms. But I also saw that Kamilia shared on her Instagram some questions you could ask your doctor, and I wanted to share some of those with you. She said you could ask, will treatment options be the same when I'm in perimenopause as they are when I'm actually in menopause? I think that's a great question. How do I track my symptoms? How will I know if these things are working or making me feel worse? And can I still get pregnant during perimenopause while I'm on hormone therapy? Great questions to ask. Okay, I'm going to pray for us. Let's go. Lord, I thank you that you made our bodies. I know it feels not very much fun to have our bodies changing and developing differently and these fluctuations in hormones, but it's also amazing how you designed us. And I pray, Lord, that you would give us wisdom on how to navigate these times. I pray for a woman who's listening that she would get the extra help that she needs, particularly if her mental health is not where it's always been or it's getting worse, that she would reach out to someone, Lord. I pray that you would give us discernment on what is for us and what's not for us. And thank you for these doctors and the research they're doing and the information they're gaining to help women not just survive, but thrive in this season of life. In Jesus' name, amen. Okay, y'all, join me back here next week. I've got 2 dads on the show talking about how do you build spiritual habits in your home based on the habits science that we know. So I'll see you back here next week. Bye.
I hope you enjoyed this episode of the Don't Mom Alone podcast. If you're wanting to connect with more people and more resources to help remind you that you're not alone, head over to don'tmomalone.com. That's where you'll also find show notes with any links mentioned by our guests. Most importantly, I want you to know the good news, the great news that you're not alone because God has promised to always be with you. With faith in Jesus Christ, the one who died for you and rose again, Jesus said when he left, he was going to leave a helper, a comforter, to be with us. God in us. Moms, that's superpower. So while you're washing dishes at your kitchen sink, while you're driving to and from work, while you're feeding that baby late into the night, while you're cleaning sticky floors, God promises to be just as present with you as when you're worshiping in a church pew. As it says in Zephaniah 3:17, the Lord your God is with you. He is mighty to save. He takes great delight in you. He will quiet you with his love, and he will rejoice over you with singing. Now that's good news. Have a great day.